The following podcast is part of a certified educational activity titled Targeted Biologic Therapy in Eosinophilic Esophagitis, Practical Strategies for a Changing Therapeutic Landscape. Access the entire activity and complete the post-test at peerview.com/RGF860. Downloadable slides and practice aids are also available.
Welcome, everyone. I'm Jonathan Spergel. I'm here with my colleague Luke Bitterman, and we're here to present some new evidence and work on EoE. Our goals today are really twofold. First is to discuss the recent treatment guidelines and clinical research data relating to the management of eosinophilic esophagitis, or EoE. And the second is to apply the latest clinical evidence on targeted therapies into the therapeutic regimens of patients with EoE. So really, we're going to start with hot off the presses, the latest evidence on targeted biological therapies. So question first is, why do we use the biologics for EoE? And there's several different reasons why we can. First, we can use for patients who are really sort of failing everything, sort of corticosteroid refractory patients, or patients who can't tolerate corticosteroids. The other big reason why you can use biologics for EoE is that you're really now targeting that individual pathway, so really being very specific, as EoE is an allergic disease. And related to that, since it's an allergic disease and you're targeting an allergic pathway, you might be able to target multiple forms of atopy. So using a systematic treatment, you can target not only their EoE, but other atopic diseases, such as asthma or atopic dermatitis. And then there's a benefit of weekly versus daily therapy. I mean, most of the biologics are injections versus daily therapies are orals, so the plus or minus of each, but this is another potential benefit that some patients and families like. So the first biologic we'll talk about is dupilumab. It's been approved in US, United States, UK, Europe, and Japan for the treatment of atopic dermatitis, ages 6 months and above, moderate severe asthma, chronic rhinosinusitis with nasal polyps, prurigo nodularis, as well as eosinophilic esophagitis. So it's been promoted for a lot of different type of what we call type 2 diseases. And the little pictogram looks at the signaling pathway for IL-4 and IL-13 as these molecules exist. They bind to a receptor and lead to the signaling and activation of JAKs and STATs, leading to activation and release of various cytokines. So we'll first talk about some various highlights for the American College of Gastroenterology meeting. So the first thing we'll do, we'll present the abstract presented by Mark Ruthenberg at the American College of Gastroenterology meeting in 2023, just recently, and he looked at a sub-analysis of the pivotal phase 3 Liberty trial. And this analysis, we're looking at whether or not being on a PPI made a difference or not. And we'll be looking at not only histology, some symptoms, and endoscopic results. In this first panel, we're looking at Part A and Part B, which patients were randomized either to placebo or dupilumab, weekly doses. And again, we're looking at eosinophil counts or histology. And we're looking at here the response of looking number of patients who had eosinophil counts less than 6, which was one of the primary endpoints in the study. As you can see, whether you were on a PPI or not, it made absolutely no difference. The patients who were on placebo had anywhere from about 4 to 8% response rate, while the patients on the PPI or not on a PPI, both worked, had a response while on dupilumab anywhere from the mid-40s all the way up to 70%. So this shows that being on a PPI, you're going to respond to dupilumab whether or not you had been on a PPI in the past or not. The second thing we're going to look now, this is looking at symptoms, which was the other primary endpoint, which we looked at something called the DSQ, or the Dysphagia Symptom Questionnaire. And here again, the patients on active therapy, which is the purple bars, and placebo, which is the orange bars, patients on the active bars did better than the patients on placebo. It's not statistically significant for everything, and some of that's probably due just because we're looking at very small ends, so you don't have a tight error bars, but it really shows that patients got better. Again, for symptoms, the other primary endpoint, whether you were on a PPI or not. So showing that the drug works in PPI naive or PPI patients who have been on PPIs in the past. Luke, any other additional thoughts you think about with this abstract, with the use of PPIs or not, as you present the next abstract?
Not really, dear Jonathan. I think you hit the nail precisely on that very abstract. And I just might add that as a clinician, I think it's reassuring to see that you get the efficacy, or that you can see the efficacy of that drug regardless of PPI use. And I would draw the conclusion that if I don't have a clear indication for a PPI, for instance, reflux disease, I would try to stop it under a successful maintenance therapy with dupilumab.
Yeah, clinically, we're doing the same thing, and it seems to be working.
Okay, so now after you mentioned the symptoms in the Liberty program with or without PPI, this is another very interesting abstract looking at the evolution of symptoms, looking at the DSQ, so the validated severity of trouble swallowing with a 14 days recall period. And I think, Jonathan, you would agree with me, it's extremely crucial nowadays to look at symptoms in EoE if we think about other studies and compounds, be it IL-5 or IL-13, where we have been seeing a dramatic improvement of histology, but there is doubts whether this also translates into an improvement of symptoms. And this is now looking again at the Liberty program you just introduced already. So this is a way of looking how do symptoms evolve under therapy. And you see at the top curve, this is the improvement of symptoms on the left and the worsening on the right of the y-axis in the middle. And for the top, this is the verum, dupilumab, and placebo at the bottom. And what is elegantly shown here is that a fair amount of patients, virtually all, will have some form of improvement of the DSQ under the verum therapy, and only a very tiny fraction with no improvement or worsening. At the same time, if you look at the placebo group, there is a not so clear picture. You have some placebo response of symptoms, but it's less pronounced than with the verum, and you also see a disease worsening. So this study elegantly shows us, this is the phase A of the trial for weekly dosing, that you have a significant benefit also in terms of the symptoms. Now, you already mentioned that there is a phase B of that study where there was also dosing every other week. And what we know from the program is you saw an improvement in terms of the primary endpoint, histological response and remission, but the effect on symptoms was less pronounced and didn't achieve clinical significance. And with that way of showing the results of symptoms, you can also see that the difference to placebo is less pronounced here with the dosing every other week. So this is an interesting way of illustrating the benefit in terms of symptoms of the weekly dosing. This is about how would therapy work in treatment-naive patients with EoE versus those that already had been exposed to drugs. And I think this is a critical question in clinical practice, because if you look, for instance, at other inflammatory diseases of the GI tract, and IBD may be a good example here, what we have been consistently learning in recent years and decades is whenever there is a patient that had failed standard therapy, the chances of a worse responding to an emerging or a new drug are considerably worse. And the big question now would be, what is with the dupilumab? Is there any difference whether a patient has been previously exposed to PPI and topical steroids, and even more so if the patient had been refractory? And if you just look here at the rates of histological remission at the table, so that would be the third line here, the reassuring numbers that you can easily appreciate here is that there does not seem to be a crucial difference between patients that never had been exposed or failing previous therapy and patients that had been seeing and receiving PPI and topical steroids. And amongst all the other items here in the tables, let me just highlight the prior TCS, the prior topical corticosteroid use, and specifically the corticosteroid refractory patients. And I think it's really encouraging for a clinician to see that the response rate was very high, with more than 90% even in that population. So the bottom line from that abstract appears to be that there is no significant difference in patients that had been failing topical corticosteroids and or PPI prior to receiving dupilumab, and this is certainly important and encouraging to see. Okay, so I'm happy to present now another part or another twist of the Liberty program. We have been hearing quite a lot already on that program from you and also from myself. Now, another important question as a clinician is to look at whether body weight, BMI, might have an impact on the response to therapy. Why could that be? I mean, it's evident that if you have a very high BMI, the dose that you require for a biologic, for a given agent, could be different according to BMI. We have been seeing that and learning that for the last 20 years or so with infliximab. And the question now would be whether there is a signal that patients with a higher BMI in EoE would show differences in response and potentially less robust clinical and histological efficacy. And the simple answer to that question is a no. If you look at the results of that study, according to BMI, there is no indication that patients with a higher BMI have a less consistent response to the key endpoints presented here on the table. And I think this is reassuring to see that data and to know that from the perspective of a clinician, if you deal with a patient that is obese or has a high BMI in the overweight section, there is no indication from that data so far that a higher dose would be required on top of that. And with that conclusion, I would like to hand over once more back to you, Jonathan, for a next abstract.
So now we're looking at an abstract again presented at the European meeting, again looking at Liberty. And this is looking at improvement, again, placebo versus dupilumab, looking at whether or not the improvement in endoscopic findings now. So this is EREFs and histology, whether or not you were on active or placebo, whether you were on prior steroid use or not. So looking at the panel, we first look at in the endoscopy whether you're on swallowed steroids in the past. As you can see, there really is no difference between the two. Whether you're on steroids in the past, your endoscopy findings was changed by just looking the visual endoscopy. And the bottom is now looking at histology, what I talked about before, both the grade analysis and the stage analysis, looking at prior use of topical steroids. Patients respond throughout. It really seems to make no difference along those lines, looking at that. So patients really, prior use of medication, we looked at PPIs, now we're looking at steroids. Patients really respond to both, either at week 24 or week 52. In these patients, really telling us that patients get better regardless of prior therapy. And I'll pass it back now to Luke, who will now talk about our next abstract.
Yeah, thank you, Jonathan, for showing again this data on the topical steroids. This is reinforcing a bit to what we already have seen from the American abstract in the naive and not naive patients. Well, this next abstract, as you hand it over to me now, is about cendakimab. So cendakimab may be a bit comparable to dupilumab in the mechanism of action. It's another biologic. It's also a monoclonal antibody targeting IL-13, but it's only targeting IL-13 in contrast to dupilumab with a dual cytokine profile. And so this antibody is also at the current stage of development. We have not been seeing the phase 3 data yet, but we have been seeing the phase 2 data. And so this data presented looked at whether there is changes in the gene expression profile in EoE patients that were exposed to that drug. And well, this is what you would expect. What this study found is that some of the key downstream signals of IL-13 signaling were shown to be affected. And this is, so to speak, a study to really look at the epithelium and at the epithelial cells and to investigate whether the pharmacodynamic effect of the drug is in place. And there were indeed interesting observations in terms of that pathway. And I think this is important work also with the question that Jonathan also addressed before when he showed the data of the HSS, specifically looking at fibrosis. So the big question now with these agents, including cendakimab, but also dupilumab, is as to whether these agents also have an effect on fibrosis that either is already there in the sense of potentially reverting an established fibrosis or to halt the progression of fibrosis. And this is why I think such work on the downstream effect in the epithelium is of crucial importance. And I'm excited to hear or to observe what we will be learning in the near future with regards to our emerging treatment options such as cendakimab. All right, Jonathan. So I hand once more over back to you for presenting the last abstract.
So the last abstract we'll be presenting is from the recent American College of Allergy and Asthma meeting. And this is an abstract that I'm happy to present because it is my abstract. And this is work done by one of our fellows. And we designed a clinical trial to look at what we thought was a key question, because in these trials, patients who were on diet couldn't add back foods. Could we add back foods? And what we did in this trial was we had patients who knew had a food trigger. So we did milk, egg, soy, and wheat, the four most common triggers of food, and they had to have a trigger by the standards things. They had to have symptoms, and you add the food back, they cause changes in biopsies, and they had to have it done. In this trial, patients were put on dupilumab, and then if the biopsies were normal, they added the foods back. If the biopsies were normal to less than 6, they added the food back. If they were 6 to 15, they sort of stayed where they are. If they were greater than 15 on that initial biopsy, they were thrown out. As they moved along with the food, so if you were less than 6, you get to add more foods. If you were 6 to 15, you stayed the same, and you were greater than 15, you sort of cut things back in half. As you can see, these were our initial 20 patients. Like most things in EoE, it is a predominantly male disease, and the trigger foods were the common foods: milk, egg, soy, and wheat. And as you can see in the study guideline, we can see we did biopsies every 3 months. So you would do treatment at 3 months or earlier than we did in the clinical trials. And then we did a food, added back in. As you can see, less than 6, we went odd. 6 to 15, we stayed the same. Greater than 15, we reduced. And we started with the 1 serving size, and each thing we went up to 2 serving size or ad lib, or you can add a whole new food depending on what you wanted. And this slide is the key endpoints. Basically, at the first endpoint, we had a 94% response rate. Basically, everyone responded, similar to what we saw with the naive patients, so much better than the clinical trials. As we moved along, you can see most patients, so at the first time point, 60% of the patients were able to add the food in. 2 patients, or 15%, sort of had to stay where they were, and 3 patients had to go back a step. But interestingly, at the next step, so now at longer therapy, everyone's advancing. The patients that failed before now are able to advance. And even at the ad lib dosing, basically everyone's advancing. So at the end, we had most of our patients were really advancing, and it just tells me that sometimes that longer therapy is better, that you can that some patients don't need 3 months or 6 months but may need 9 months of therapy to add back the food. And it's probably better to add back the food slowly, not ad lib at once, but add it back one serving size and two serving size and add things along. So that was what we found very exciting for these patients, because that was one of the big things that many of our patients wanted to do. Can I eat more food now? And the answer is yes, but don't do it slowly. Don't do it all at the same time. So there's two other molecules that are in clinical trials. One is the anti-TSLP called tezepelumab, and that drug is actually approved in the United States for asthma. It is now in a phase 3 trial in adolescents and adults for EoE. The second drug that's in clinical trials, an anti-KIT drug. It's in a phase 2 trial, and it's called barzolvolimab, or CDX0159. And that both these drugs, we have no clinical data this time, but we are anxious to see how well these new molecules work. Does any of this data and the true yardsticks, which we'll go over in a minute, from the guidelines, has it changed how you thought about things and where you're starting them at the current time? Have this changed your practice from all these new emerging abstracts?
Yes, it changed them, quite frankly. So in my clinical practice, so you mentioned the patients that you at the very beginning that would potentially qualify for an advanced therapy in general and the biologic in specific. And so you mentioned the groups of atopic comorbidities and also those that failed topical steroids or had side effects. And in my clinical practice, the full-blown failures, they are there, but they are not that common. But patients that are reluctant to continuously being exposed to topical steroids are quite common, and some of them perceive that there are side effects. So knowing that you have an advanced therapy option available that potentially controls these patients on the long term is reassuring, and some patients really would favor that. And what you mentioned in terms of these atopic comorbidity, I personally feel that now that we know that an agent as dupilumab is also effective in asthma, atopic dermatitis, or even the chronic rhinosinusitis with or without polyps, we as gastroenterologists are um, more detailed in looking at these comorbidities, which previously we may not have been paying the attention that they require. So, in other words, I think an agent that has a more broad efficacy profile may be even helpful also to foster the communication between the different specialities in medical practice. And I think this really somehow has changed the way we do medicine. And maybe before we move on with the discussion on dupilumab, so the abstract data that you just presented with the reintroduction of diet, I was wondering, Jonathan, some of the patients that had been under prolonged dietary treatment and you offered them the option of being exposed to the drug and then successful food reintroduction if they responded to the drug. It may not have been too difficult to recruit the patients, I guess, right?
No, this wasn't. This actually was an easy study to recruit from.
Yeah.
The idea from the study actually came from our patients. It was one of these. We
Mhm.
were asking our patients, "What do you want to learn?" It was like, "Can we add food back?" This is really what we. It was one of these like, okay, let's find out. Let's do it in a really rigorous way to find out, and doing it slowly, doing it instead of, if I worried if I did it ad lib, and I think if we did it that way, people would have failed. But doing it this way, it really made a difference. Going slowly made a difference. It was definitely a patient driven thing. And I agree. Um, the all this other abstract that it depends whether you're steroid responsive or not, seen steroids before or PPIs before or not, that it really works in everyone is really encouraging, because that's really, I think, what we see. We often see the secondary and tertiary referrals for these patients. It was very exciting. And as an allergist, I've been using dupilumab for about 7-8 years now for atopic derm, and it's really exciting to see that, hey, I have one drug that can treat many of my patients. So it's a really exciting thing to see. This is a slide. This is one of many, a couple different algorithms out there for treatment, and I think it really is a really useful algorithm for when we think about treatment. This is from both the sort of bits and pieces from both the European and the American allergy societies, and GI societies. I mean, a lot of it's the same. I mean, the diagnosis is no different, right? We still got to make sure they have the disease. We're not missing anything else. And then it really comes to a shared decision making, which I think it's really important to involve our patients with, is what's the right thing. We typically do PPIs first, because PPIs, hey, my mind is, if you're getting better with an over-the-counter medicine in the United States, you're pretty good, you have mild disease. And after that, it really depends on the patient, what they want to do, some patients want to take the allergen out, some patients want to do a shot, and some patients shots scare them and they want to use steroids. And I really think you have to really go over that and do what we call shared decision making. I mean, that's the way I've developed my way I treat patients, and I really like this sort of algorithm that's been laid out. Luke,
Yeah,
what you guys do?
I can only fully agree with you, Jonathan. I think this shared decision making, it may be sometimes used as a bit of a buzzword, but I think both of us agree that it's really crucial and important. So we always tend to provide the patients all the options that are out there, including diet, PPI, topical steroids, and now also dupilumab. And I think it's important to present those options to the patients and to also discuss the pros and the cons. And this shared decision making also makes it much easier than to follow the therapy. I think it increases the adherence and the motivation of the patient to follow the therapy, and it potentially may even increase the response, right? If you as a patient believe that you were actively involved in the decision, this is most likely also a promising signal for the ultimate response. And what you now mentioned also with your given study that you presented at the very end, I think to have more options available, this provides us with the flexibility we need. For instance, we have a lot of patients that at a certain point in their life say, I want to do the elimination diet, I'm fed up with the topical steroids, but I could also imagine that such a patient comes to a point in his or her life, maybe an exchange year whatsoever, travel to a country where they say, I want to have the liberty to eat whatever I want. And then they may be more motivated to start the drug therapy so that they have this liberty. And who knows, at a certain time they may switch back to diet. So I really think work as yours is important to show the mobility between the different therapies, and I also fully agree with you that the decision making together is absolutely key.
Yeah, thank you. I mean, I see this a lot in my young adults. When they go off on their own, they want to do one thing, and then they change their mind. They go back to do something else, and so that group is really a great group for that. And I do think it's important that we discuss all the options with our patients. I am.
Yes, even more so, Jonathan, if I may, it's important because if we look at the guidelines today, at least the guidelines in my GI world, like you as allergists and immunologists, you are much more advanced in terms of positioning these agents. But we as gastroenterologists, if you look at the major EoE guideline that are available, so the European one is 217, dupilumab isn't even mentioned, evidently, because it was not present at the time. But also the German and the British guidelines, very recently published 22 and 23, they only mentioned it, dupilumab may be considered. And so it means that we as clinicians have to find the correct place of dupilumab and position the drug, when to use it, when not to use it, what to use first, or use dupilumab even first line. And one way of doing that, in the lack of a clear guideline and evidence on the positioning, is certainly to discuss it with the patient. And as always in medicine, we have to get our experience as clinicians and to know the drug better, right?
Yeah, which brings up our next slide, which is when we would actually consider when to do first line. This is the exact point. And I think there's some ones that are pretty easy to think about it. As first line is the one we were talking about, for the person who has, hey, I'm going to give you one drug. And this is when we first used it. We were using initially for patients who had asthma, and they had EoE at the same time, but we needed it more for their asthma. But is that shared decision making that's went along the line, and then it's the step up, or potentially even as first line for some of these patients, the patients who have really severe disease. And I think we don't know with the patients who have that strictures or the failure to thrive, whether they use that as a first line. But clearly, if you're failing things, that's where you are, whether you're failing because you don't want to do it, or that you failed before, or you're having adverse events. These are all really important reasons to think about when we think about it for first line versus step up. And some of this can go back and forth. There's a definite crossing over whether some are first line, whether second line. I really think as we move along, especially for some of our severe patients, whether or not to step things up. Because I think now in the GI world, for the IBD, these often jump to biologics first for some of your severe patients. And I think we may end up doing the same thing in EoE, but still to be determined.
This is definitely a key question that you raised, Jonathan. And if you think back to biologics in IBD at the very beginning, when they came up more than 20 years, 25 years now from here, when did we start to use them? In the very severe last resort patients, right? We were severely reluctant to start them. And then we realized they do work in the severe cases, but we also realized they may be working even better if you start them more earlier in the course of disease. And now the same may happen if a drug like dupilumab emerges in the field of IBD. The difference here may be the standard therapy is not that established as it has been in IBD. And I really also think the more we start to use the agent, it may be perfectly realistic to think that we will be using it more early. And I'm fully agree with you, specifically severe patients. So if you have a patient with already a stricture and a severe inflammation at baseline, and where you feel as a clinician this smells like trouble to come, maybe another food infection whatsoever, this may be a perfect candidate for dupilumab right away. And also, if you look at the label, the way at least it will be in my country, or it is in my country, you are not forced to have a failing therapy upfront to start such a treatment. And I think with the increase in experience, Jonathan, we will have to learn the better positioning. And well, this is what it makes it so exciting. And we as experts and our colleagues, we have to work on guidelines and provide guidance to other colleagues, right?
Yes, I think you're totally right. I agree with you 100%. It's going to be really interesting to see how things change over the next several years as we learn more and more. I mean, we know we've been using it for other things for a while, so we know sort of some of the safety profile, which has been really reassuring. And we'll see what these additional other biologics that will be coming out besides dupilumab, where they fit in the pathway, whether they're equivalent, superior, inferior, don't know until we get more data, but it'll be really interesting to see in the next several years, as I think the therapies are really going to change pretty dramatically.
Absolutely. So it's going to be exciting times in the next years, not only in EoE, but in immune-mediated Th2 diseases in general. Thank you so much again, Jonathan. It was really a pleasure. I also like to thank PeerView for having us, and thank you so much.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RGF860. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals.